Hey everyone, it's Patrick, and today I actually have a question for you. How would you like to have your board exams paid for? Well, thanks to PhysicianLoans, we're going to be launching a contest soon. The grand prize, we will pay for your USMLE Step 1 or Step 2 registration fee. First through fourth year U.S. medical students are eligible, whether you've taken the exam already or not. We'll be running the contest till July 1st. The details and rules are forthcoming, but if you want to be the first to know and to get a head start, head over to InsideTheBoards.com, sign up for our email list, and you could win your USMLE exam registration fee, as well as some other cool prizes. Thanks for listening.
Welcome to the Inside the Boards Study Smarter series dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed on your exam.
Hey everyone, today it is part 2 of our hematology discussion for our Study Smarter mini-series for the USMLE Step 2 and Shelf Exam Internal Medicine Edition. We have a 59-year-old male being evaluated for a 1-week history of fatigue, forgetfulness, constipation, polyuria, and polydipsia. He has hypertension and diabetes and is on lisinopril and metformin. 2 months ago, he had a left lower lobe pneumonia. On physical exam, presently, he is somnolent but arousable, but quickly falls asleep mid-sentence. Vitals show afebrile, normal blood pressure, a heart rate of 123, and a respiratory rate of 18. His mucous membranes are dry, and the anterior rim of his eyes are pale, but his lungs are clear and his heart rate is tachycardic, as mentioned. Laboratory exam shows a normal white blood cell count, a hemoglobin of 8, normal platelets, elevated calcium of 14, the normal's 10, a creatinine of 2.9, total protein slightly elevated 8.2 from 7, and an albumin of 3.2 down from 4. His urinalysis is negative for protein, and a chest x-ray shows osteopenia without acute pulmonary findings. Blood smear is normal, and the patient's calcium is treated with intravenous fluids and bisphosphonates, and his mental status improves. A bone marrow biopsy is performed. What is most likely to be seen on the biopsy? It's another dense one, huh?
Yeah.
So we've got A, plasmacytosis, B, myelogenous blasts, C, mature lymphocytes, or D, metastatic lung cancer.
Do 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 do. Cue music here. So, this patient has, I think the most important thing to talk about here is his hypercalcemia, which corrects even higher given his hypoalbuminuria or hypoalbuminemia, whatever. He sounds like he has myeloma. So on the, what is it, bone marrow biopsy, he's going to have
just one myeloma or multiple myeloma?
Multiple myeloma. So he's going to have a plasmacytosis, right? I think greater than 10% is sort of the cutoff we like. So I would go with A, plasmacytosis.
Yep, that is correct. What would you say is the most attractive distractor here? I would say it's metastatic lung cancer.
I would probably go with that too. Honestly, I like pin on these renal cell patients in my mind when I think of this. So if that had been renal cell cancer, I really would have had to like step back and think about it.
Wait, why? Because of his creatinine and.
So yeah, it gives you the picture, and I've just had a patient who's had like severe hypercalcemia related to his renal cell. So that just kind of sits in my mind when I start to see this picture.
Yeah.
This exact patient, the only difference being that they had a metastatic renal cell is our diagnosis.
Well, that's diagnostic momentum, focusing on one diagnosis and fitting the pieces into it. So, Stuart, that is a clinical cognitive error. So, it's the morning and you're
How
off.
about this? Any paraneoplastic syndrome is what is the things that also pique my interest when I think about them.
Yeah. So let's just line by line on this vignette to highlight. So we've got a 59-year-old guy with constitutional symptoms. His history isn't all that revealing in terms of pointing out the diagnosis. But importantly, we see that his lab findings have a few things like an anemia, right? The hypercalcemia and the elevated creatinine. And importantly, the chest x-ray shows osteopenia without acute pulmonary disease, right? And presumably they would tell you about more chronic pulmonary disease if, for instance, there was a mass found. And then his hypercalcemia is treated, and we see a clear connection between the treatment and improvement of his symptoms. So I'm still thinking I'd be between metastatic lung cancer and plasmacytosis, but for the fact that his x-ray is normal, so I'm going to rule out metastatic lung cancer just based on that and go with the plasmacytosis. But keeping in mind that, like you said, all paraneoplastic syndromes, so if he had, non-small cell lung cancer, it's likely to produce parathyroid hormone-related peptide, PTHrP, which can stimulate the release of calcium from bone, and in so doing also predisposes to acute kidney injury.
Take some liberties here with this question because they're saying there's a normal chest x-ray and they're saying this person is toxic. He's really sick.
Yeah.
And you would expect if this was lung cancer that was bad enough to make this patient look this sick, it was probably all over the chest x-ray, right?
Yeah.
The fact that you have a chest x-ray here that is fairly normal makes it difficult to say that would be metastatic lung cancer. If it was metastatic, there would be probably some large masses seen on the x-ray. Now, in reality, are you going to use an x-ray to diagnose that? No, but for the purposes of kind of reading into why it's not metastatic lung cancer here.
Yeah. And I mean, his symptoms can be explained basically by hypercalcemia. He's got osteopenia.
He's somnolent.
Yeah.
Right. Those are the main things you're going to see.
And then
they've got this part where they talk about him coming in and out of consciousness, and then his calcium is given. You give fluids for for hypercalcemia, and bisphosphonates typically give something like IV zoledronic acid or zoledronate. And funny thing, treating with a bisphosphonate will lower the calcium over time and give it 48 hours, and then they start to act a little bit better, right? Another thing for high immediate calcium reduction would be something like calcitonin.
Yep. Wonder if it's clear enough to say, you see somebody with osteopenia in a vignette that is not clearly, women get
osteopenia with
osteoporosis. Jeez.
Oh yeah.
Man, common disease. Going to those zebras.
T-score grade less than -2.5.
Oh, yeah. And I have a story on that, which I'll tell at some point, where during my board exam, I told the examiners that it was -1.5, and then had this moment walking out of my OBGYN boards and thought, wait a minute, that makes no sense because it's a standard deviation. And 2.5 makes a lot more sense putting patients outside the the bounds of normal distribution. So at any rate, you see that osteopenia on the chest x-ray, and then the myeloma basically gets in the marrow, crowds out other cells. So you see the anemia, the bones can't produce red blood cells normally. And then you also get these immunoglobulins produced, which predispose patients to infection like pneumonia and renal failure as they get deposited in the kidneys. What else to know about multiple myeloma, like high-yield pearls?
Like the protein gap might be useful. So here, this patient had a total protein of 8.2. They told you normal was 7. And you're like, that's not that elevated. But then their albumin is also low. So their protein gap is actually wide. That's a useful number for when you're thinking about multiple myeloma. You can have things like you talked about the kidney injury, but it can also cause what you've got. What is it? AL amyloid floating around. So you can have like amyloidosis sort of picture with deposition in any end organ, or you can have like heart failure, or basically from excess protein, like restrictive heart failure. Like, what else is important here?
What about the M spike?
Oh man, everybody loves the M spike, right? So if you do protein electrophoresis, your SPEP for the serum, you see this monoclonal, or it's not necessarily a monoclonal spike, is it?
I mean, I think,
yeah,
isn't
it is. It is a monoclonal spike.
M for monoclonal.
It's not an IgM spike, is what I think is something that some people get confused. And then you can actually you can do a UPEP as well and look for protein in the urine, right?
Yep. What about Bence-Jones proteins? Are those just the immunoglobulins you see in the urine?
So I think they can be seen outside the urine as well. I'd have to look into that. But I think for the purposes of step 2, that is a fair simplification, right?
Yep. Yeah, it is. That's fine. But yeah, I guess the other thing you could see Bence-Jones proteins called, which you likely would on an exam that's trying to move away from eponyms like this, are immunoglobulin light chains in the urine, like kappa chains or lambda chains, they say. What's interesting, though, if he had no protein in the urine, I feel like, wouldn't you have proteinuria with a bunch of immunoglobulins in your urine?
So here's the thing about that. Here you have this whole picture that's sort of painting you toward myeloma, and then they give you this one fact that kind of lowers myeloma on your differential, right?
Yeah.
And that's sort of what these good test questions are trying to do. They're trying to make you decide on, do I have enough evidence here to go with myeloma, or do I need to start thinking about something else here? This one's kind of a hard giveaway when, at the end of the day, they do a bone marrow biopsy and they ask you what they saw.
Yeah.
I don't know what metastatic lung cancer looks like on the bone marrow biopsy, but I probably wouldn't pick it just because of that, right?
Yeah.
In my mind. But for these, like I said, these good vignettes, they have a lot of information, and sometimes they give you negatives, and in reality with real patients there are negatives, and I think that's helpful for making you think, is that an important thing enough to have to call this multiple myeloma, or are we good enough here with the other information we have, right?
And I would say, like, pertinent positives and negatives are often the way they rule in or rule out one of the answer choices. Like, that should be obvious, but I think, like, systematically when you're like, oh crap, there's a bunch of information here, I'm torn between answers, like, look at those pertinent positives, look at those pertinent negatives, and if you can come up with a reason why one of those rules out, an answer choice that you're torn between and another, I would just go with ruling it out based on, even just those one items. You might be wrong some of the times, but it's a decent.
And that's what the test and step 2 is really focusing on when they're asking you a what is the diagnosis kind of question, and they give you all these similar options and you're thinking, gosh, this could be any of these. They know that they're wanting you to go down the routes and say, what's the most important thing here? What are my pertinent positives? What's the pathognomonic finding here? Sort of like the last question we were just doing. If you didn't have those smear results, it could have been any of these answers, right? And here they've given you this serious picture for myeloma, but if they had thrown Waldenstrom's macroglobulinemia on here as well, gosh, what are you going to do without knowing the percentage of things?
Yeah. I'd love to get into that, but my son is currently experiencing an asthma exacerbation, so I have to go give him inhaled fluticasone and, more importantly, albuterol before he escalates. So we will end this here, and actually, probably the next episode, we will be covering pulmonary diseases for step 2. Thanks to OnlineMedEd today for generously providing this content. And if you haven't got your premium OnlineMedEd subscription yet, and we know you're going to, please do so by clicking the link in the show notes. OME gives us a return of a little bit for driving people to their platform, which helps Inside the Boards. So if you're going to get OnlineMedEd anyways, please click our link in order to do so. Today's music is by DJ Bezo, aka Augustin Beeman. The song is King Jeff and His Apprentice Bart. We'll be featuring more from this young emerging artist who also happens to be my son. I'm just really proud of the creative work he's doing and wanted to support him in his endeavors. So thank you, Augustin. We'll look forward to more of your art, which we'd be happy to feature on the ITB podcast.